Good evening, everyone. Thank you for joining us this evening. We always like to have people join us and ask questions and engage, and hopefully you've had a chance to watch the parts 1 to 4. If not, they're available for you to watch. Please ask questions, email us with questions. Dr. Elorriaga is always so generous with his information. He will answer, he'll send us articles. But for tonight, like always, if you have questions, we'll get to them at the end of his talk. If you can just type them in the Q&A chat below. But other than that, welcome Dr. Elorriaga again for part 5.
Thank you, Sulin. Glad to be here again, and thank you everyone for your participation and for your patience on the slow but thorough building of the necessary updated model of physiology, neuroanatomy, functional anatomy necessary to become an effective practitioner treating pain with movement disorders. Today is a very exciting day for me because we are going to jump on the second part of the equation. We've devoted parts 1 to 4 to lay a foundation of neurophysiology of acupuncture, neurophysiology of pain, very necessary to fully analyze that part of the pain with movement disorder. But the most exciting part for me is not that, but the part that comes today. But before, I'm going to start with a summary, as I always do, of the preceding session. So the summary is we are proposing a clinical methodology that we call neurofunctional operating system or neurofunctional logic or neurofunctional approach to treat pain with movement disorders that is based on a selection process of the best neuroreactive sites available for the needle placement, that for the acupuncture part of the treatment, which is not the only one, but the main one. So the analogy that I've been using all along is chess move. We have one move. In this case, we have more than one needle, but we want that to be the best available move. And for that, we need to truly understand the problems from these dimensions, neurofunctional, neurometabolic, neuroanatomical. And this neurofunctional and neuroanatomical analysis definitely involves a deep understanding of the organization of the peripheral nervous system, both anatomical and functional, and the distribution of the nervous system, sensory and motor. So we need to know the receptor sites on the different tissues, the type of nerve receptors, ligaments, capsules, muscles, tendons, tenoperiosteal attachment, where the peripheral nerve trunks can be reached, because all those are our targets. And I spoke about the standardized methodology that I developed over many years of practice that divides the inputs into local, neurological local, axial, posterior primary rami territory, and systemic regulatory inputs, which are needles in miscellaneous locations, head, neck, ear, distal hands, distal feet, that are intended to stimulate mostly neurohumoral, neuroendocrine responses centrally that will have a general effect. That's why I call that systemic regulatory inputs, and they are not segmentally neurologically connected to the problem. And each of these groups of inputs can be studied, should be studied into detail. And last time we spent a fair amount of time reviewing the concept of neurofunctional blueprints, which is a pattern of needling based on the neurofunctional articular innervation of a given area, and based on that basic movement analysis, going from impaired movement to muscle to motor nerve to input. That's the game that I played with examples relative to a hypothetical shoulder dysfunction. And this triple approach obviously overlaps criteria, but is helpful to train the brain to think in each of these dimensions. Topographic approach based solely on the local innervation, which you need to know very, very well in detail. That's the neurofunctional approach, which muscles move this, which nerves innervate the muscles, which cutaneous branches give off articular branches, etc. And the structural approach, what is here, which will be the companion of examination skills, learning to identify by palpation particular anatomical loci, and then declaring them or using them as treatment targets. So that was the last time presentation, which was secret number 5. I found this quote this week that I like very much, and I'm sharing with you. Don't go where the path may lead. Go instead where there is no path and leave a trail. Ralph Waldo Emerson. A beautiful manner of expressing what I believe is part of the task of excellent clinician, a committed clinician. It's not a matter of repeating ourselves, copying what is being published, and not going anywhere else, because patients need us, and we have to do our very best to help them. And that is a sacred mission in my view. And we need to go above and beyond biases, dogma, and practice what Hippocrates proposed, primum non nocere, of course, first not harm, and beyond that, to find any legitimate strategy, any legitimate technique that is going to support the patient's physiology. And this is what we are doing here. So we are not concerned that this is not 100% tested, that this is sound, this is empirically very valuable. And I will give today powerful reasons for you to embrace fully, if you haven't yet, a neurofunctional approach. So the secret number 6 is that the knowledge of neuromotor, neurosensory, neuromechanics, biomechanics are indispensable. It's not enough to know the descriptive gross anatomy. You may know that 100%, but the body moves. See, my hands are moving, and movement is the foundation of understanding the interaction of the body with the surrounding forces, starting with the most powerful of those, which is the gravitational field of the Earth. And the design, you need to study and understand the design, because the design of the body, like the design of a car or a motorbike, is at the service of carrying on certain functions, certain tasks. And within those tasks, there is one we don't talk a lot about, but it is the fundamental one without which you could not continue to move and without damaging the elements, the structural elements of the body, the same as a vehicle. So we're going to dive into what is really going on here. And when you think vehicles, is easier because we are more used to see and understand the simple mechanics of a vehicle. So a vehicle that moves needs a system to transfer the force that puts the axis in motion and transfer to the wheels. So that's the transmission. And then it needs a system to absorb the forces generated by the interaction with the road, which is the suspension. And of course, you have the engine and the engine parts that's devoted to transform chemical energy into kinetic energy. So the fuel or the electricity becomes movement. All right, so we jump into my favorite topic. And this became my favorite topic over the years, not right away. This was a not a eureka moment like Archimedes or Newton may had with the apple hitting his head, but this was a slow realization about patterns and thinking and about injuries. And in analyzing that, I figure out, because I didn't find this information anywhere assembled the way I'm presenting it to you. I realized that this was the ultimate uh, adaptive demand on the body. And this is very simple. It starts with a formula, physics formula. That's the formula of the kinetic energy. Kinetic energy is energy associated with movement, and it has to do with two of the physical dimensions of things that could move, which is the mass, m, and the velocity of movement. So as we move a vehicle or a biological system, energy, kinetic energy, is generated. Before it was chemical energy that, due to a number of processes in the cell, becomes mechanical. And that mechanical energy produces the shortening of actin myosin myofibrils that in conjunction with a myriad of other micro units, it produces a macro movement, which is the acceleration of a mass, a body part, or the acceleration of the global mass of the body. So that kinetic energy follows the same principles than any other form of energy in the known universe, and is that according to the first principle of thermodynamics, energy is indestructible, energy cannot be created, cannot be destroyed, can only be transformed. The first principle of thermodynamics is the principle of conservation of energy, and nothing in our known universe escapes this law. Therefore, if energy is generated in the transformation from chemical to mechanical, and now there is movement and there is an acceleration of a mass, there'll be energy accumulated. That energy has to be dealt with. That dealing with energy has only a limited amount of strategies. This, before I reached that other slide, is the fundamental and basic environmental constraint that every living creature has, and is that we live on a very big mass, the Earth, and that very big mass attract us, our mass, which is a lot smaller, and in attracting us incurs into a mechanical behavior described by Newton on his three laws of movement, the third of which, or the third of such laws says every action generates a contrary reaction of the same magnitude and opposite direction. So the Earth attracts us, meaning it generates also a force that's equivalent to our mass. That's if we are stationary, or if we are moving, you will have to add the force generated by the generation, the acceleration, and at any rate, we will have to deal with that force, because once again, we cannot destroy energy or just dump it when we don't want it. And this is the foundation of most of the issues that we deal with in clinical practice. They stem from the fact that we are moving in a gravitational field with a very powerful pull, and whether statically or dynamically moving or simply maintaining a position that we call posture, we have to generate energy to counteract the vertical compressive vector, and otherwise, for instance, the apple will fall from the tree the moment is not connected to it. Gravity always wins and prevails. And the whole talk today on this particular part of understanding the consequences of the kinetic energy management. So kinetic energy only can be handled in three ways. One is, okay, you use it for movement, you keep moving until the energy disappears. So as if you're swimming, you go and pull, and then you no longer pull, and then you wait until the friction with the water makes your body stop. So that was one way of managing kinetic energy, pretty easy in the water anyway. Or you can transfer the energy of the movement to something else, a ball or a javelin, as it's been illustrated here. So chemical energy changes into mechanical in your arm, you accelerate the arm, the arm has the javelin held by the hand, and when that acceleration is maximum, then you release the javelin that carries the kinetic energy, the majority of the kinetic energy, and then the rest that's the follow through action that also is the way of via movement spending that kinetic energy that cannot be destroyed. So that's why every movement needs some sort of follow through in order to disperse some of the forces, the reaction forces generated by the movement. Also, simultaneously, kinetic energy can be spent or absorbed and dispersed via mechanical deformation. And that mechanical deformation typically is carried on by tissues that have that property, elasticity, flexibility, supple, etc. Those words that refer to the ability to change molecular configuration without breaking, and then typically, if it's elastic, to recover that configuration. But at the end, two different strategies here. One could be stretching, So the tissues of the arm here on the follow through a stretch, and on a stretching, they act as the brakes, and they don't break. They just simply suffer a little deformation, combination of tissues here, muscles, interstitial connective tissues, etc., until there's no more energy, and then the arm stops. And also compression, which here the foot is pushing the ground is pushing the foot, and still we need ongoing energy production, because if we stop producing energy here, we would collapse, as this is a constant game, the circulation of reaction forces from the ground reaction force. And also some deformation could be total. Let's say that this accelerates so much that the tissues cannot take it, then they will rupture, and that there is your energy gone. One way or another, the energy needs to be absorbed and dispersed. That's the law of thermodynamics. Whether that's done in a sustainable manner, or that is done in a non-sustainable traumatic manner, depends on many factors. And finally, a little bit of the movement will be dispersed in the form of heat. If you move your hands like this, obviously you're going to generate some heat on the palm, or if you put a little piece of wood and do this against another, you're going to generate heat on the tip, and eventually you may even produce fire. So it's important to know that in general, movement and deformation are the most effective ways of handling reaction forces. Let's study how in architecture and in biology forces are handled, reaction forces. So the first strategy is compressive strategies. So you have a mass, whether it's a bridge, an aqueduct, a T-Rex, and that mass is attracted by the mass of the Earth. If you want that mass to stand tall, you need to oppose something that compressive vector from Mother Earth. In this basic design, that's accomplished by accumulating a lot of matter here. So you build these huge pillars, and then the weight of the bridge will be supported by the pillars, and the bridge will not collapse. That's how basic architecture engineering solves the problem. Now, this is very onerous because it takes a lot of matter to fight gravity if something is heavy. You can see how the bones of the T-Rex, which was moderately big for a dinosaur, they were much bigger, but you can see how big the pelvic bones, the femur, the tibia, and the tarsum. Compare that to the small upper extremities that did not have to handle compressive forces, and they're way, way smaller. Even the jaws that had to withstand tremendous forces from the powerful masticatory muscles of the T-Rex, the bone has to be thick and big, otherwise in trying to break whichever bone of prey, their own bones will break. And this is an improvement. This Roman aqueduct in Spain is an improvement over the basic design, because by adding arches, then the weight, it doesn't go all through the same pillar, but is split and sort of circulates along this arch, and that disperses a lot of the force. So this is very effective. By the way, these stones are not not glued to each other. There's no concrete, no cement, nothing. The stones are simply assembled in a careful manner, like a puzzle, and this has been over 2,000 years and still stand there. So the arch was a huge improvement on compressive vector management. So that's the basic compressive strategies. But there are better strategies. There are strategies based on tension that you can be represented on this other more contemporary bridge that now has pillars that are way more separated than the ones from the old bridges. And they are smaller, even though the bridge weighs more than the old bridge, because these cables that are here, this is not a static thing, this is a functional engineering thing. What happens is that when gravity pulls down the mass of the bridge, then each of these cables gets some of that pull and transfer the pull to the upper pillar here, but also in combination with the ones from the other side, it kind of circulates those forces and creating a balanced situation that allows the pillar not to have to withstand excessive compressive forces. This is a wonderful design and also is a wonderful example to understand something. If these cables or some of them were disrupted and then the function of circulating the forces here was lost, the pillar will suffer excessive compressive load and will start to crack at no fault of the pillar. And this is something you have to think in clinical practice. Oftentimes, the area that suffers, let's say the knee, an area under compressive loads, is at no fault because the knee is designed to last you a lifetime. And if it doesn't, it's not wear and tear. There's no such a thing in a proper healthy body. In a healthy body, the hips, the knees, the teeth, the bones will last you a lifetime even if you live 150 years. So it's not a fault with the design, and barring some sort of autoimmune disease that destroys the synovia, the articular cartilage, etc. That's a different conversation, pathology. But wear doesn't lead to tear. Trust me on that. Indeed, there are adaptive mechanisms that means when you use the system properly, you become more adaptable, you become stronger and stronger. And tensional strategies are of several kinds, and there is one which is the supreme tensional strategy, and it was discovered because this is something that exists in nature, but it was discovered on the first half of the 20th century by an inventor, an architect, American, Buckminster Fuller, and Bucky, as he liked to be called, apply this understanding to the design of the so-called geodesic dome. And an example of that can be found in Montreal, and a building was constructed with that technology for the Expo, Universal Expo 1970 something, I think 1972 or 76. And nowadays we use that. So after the 70s, the Olympic stadiums no longer had pillars. up to that point, if you look at movies from all the Olympic Games, any or other sports played under cover, all the stadiums had pillars to hold the weight of the roof. After that, applying a tensegrity design with a continuum of some sort, could be steel, stainless steel rods, or some arrangement, no longer the weight needed to be held by compressive forces, but the forces could be taken to the outer part of the dome and absorb and disperse properly there. So the modern stadiums, they do not have, they have mm, uh, they have big roofs, even roofs like the Sky Dome in Toronto or others, and design using the principle of tensegrity. The principle of tensegrity is that there is a continuum of tension, and then that continuum guarantees the preservation of the shape because it guarantees the management of the forces without relying on compressive strategies. So this tower here is only supported by 3 points of contact with the ground, and the weight of these rods that are floating in a network of stainless steel. This cable is nothing elastic. Is a stainless steel, and this has been assembled on the ground, but then it's been put up, and there remains. The shape is guaranteed by the circulation of forces through this tensional continuum that prevents the collapse of this. So if any of these cables were cut, the whole thing will collapse like the proverbial house of cards. Tensegrity, discovered by Buckminster Fuller, also was rediscovered in biological tissues decades later. Professor Donald Ingber from Harvard University in the 70s carried on elegant studies that shed light on the microarchitecture of life that today have changed, should change the way we see the human body and biological tissues. And I will skip over the lower part of the information that's here because I want to, I mean, or no, I will not because the quote refers to that. So Professor Imber, and I recommend you read the article he published in 1980. It was an original one, 70 something, and then another one. And it's called The Architecture of Life. And it was published in the wonderful journal Scientific American. And the they were based on the studies he performed for NASA. NASA was preoccupied because after training astronauts for like years and after selecting them carefully and then training them, when the astronauts were sent to outer space, they came back in pretty bad shape, even though these were top shape individuals. And as soon as you put the system out of the gravitational field, paradoxically, the system starts collapsing. There is loss of bone density, loss of muscle mass, and extreme weakness. When they picked up the astronauts, it was pathetic because they had to carry them on their arms like little children when these were well-trained men for many years, then women as well. And they were trying to figure out why is that. So Professor Imber designed a very elegant experiment and put cells in a position that mimicked gravitational pull, so flattened the cells, and then put other cells in a round position, mimicking lack of gravity. And the result of the experiment blew him away because the cells that were flattened, they undertook mitosis, reproduction. And the cells that were kept in a round position undertook apoptosis, destruction. So, two behaviors, opposite behaviors, cellular behaviors, metabolic behaviors, triggered biomechanical behavior. That discovery is something, when I found that out, it truly blew my all my understanding of matter and physics, biological tissues, because this is the ultimate frontier. Mechanical behavior of the tissues has a functional metabolic correlate. And this experiment also explained why, when you put certain cells out of the gravitational field, the response of the cell is downregulation of genes. And if you remember, when you studied physiology, red blood cells start as a flattened cell, with the shape of a donut. And those cells, after 120 days, barely 4 months, they become round and then they disintegrate. So this is the life of a red blood cell mimics this experiment that I just mentioned. So Professor Ingber, based on this, which the big word here would be mechanotransduction, mechanical forces trigger inner reactions in the cell. So he says every tissue in the body has some disease that results from cells responding abnormally to mechanical forces. That is very deep and goes beyond the focus of today, which is the understanding of adaptations, directional adaptations of the connective tissues. But also beyond that is the notion that mechanical behavior has a metabolic correlate and could explain why relatively gentle movement therapy or movement strategies such as qigong, yoga, result in very, very clear benefits that cannot be explained in the traditional manner, like normal calisthenics and aerobic training would result in adaptations that, yeah, obviously we become metabolic and better. But yoga, qigong, you move very slowly, you barely load the tissues. However, there are a number of endocrine responses, neurological responses, humoral responses that are very beneficial. And this is the ultimate frontier, mechano-metabolic. And this happens independent of the nervous system, which is my other passion and focus of interest. But we need to think and reflect today about this. This is the first page of that article I mentioned. You can see in the article illustrations that are similar to the sculptures that I showed you. Those sculptures are from Kenneth Snelson, Snelson, Snelson. Kenneth Snelson was a student of Buckminster Fuller and became a sculptor and created all these tensegrity structures that are famous. He has a website. You go there and Google tensegrity Kenneth Snelson. You will find a beautiful PDF that he's published with explanations about how to build these structures and the idea of tensegrity. Now, tensegrity is not just something for the engineers to lighten up the bridges, to lighten up the domes of the stadiums, but it happens to be the choice of nature to design the most supple, versatile, and fast of all creatures on the surface of the earth, not talking the birds, on the surface of the earth, which are the mammals. The mammals conquer all ecosystems after dinosaurs, which were reptiles, disappear, the mass extinction, and only few cousins remain. Actually, from the dinosaurs, only one type of dinosaur remain, which paradoxically are the birds. The birds are the descendant of the dinosaurs. And then we had the reptiles that had been around for a long time, the turtles, the different lizards. Those haven't changed design, they're still around. And obviously some creatures like the shark, etc. But when you look at the unique ability of mammals. Let's see here the cheetah, the fastest mammal on Earth, able to run at 120 kilometers per hour. That if you apply that formula of kinetic energy, the square of 120 is 11,440, I believe. That multiplied for the mass, even if the mass is small, even if it was 10 kilos, it is an enormous amount of joules, which is the unit that comes from that multiplication. And that doesn't break the legs of the cheetah, even when it changes directions in a very small area. And this is because underneath there is a biotensegrity design, and this biotensegrity design has many dimensions. One is this study of the fascia of the most dense reticular connective tissue that covers the muscles and creates part of this 3D continuum. But this 3D continuum is not just macroscopic, it's microscopic as well, because all the way to the cytoskeleton of the cell, we are a tensegrity structure. So this is about design, and this is about understanding the game of forces. Now, let me tell you, of all this design, you need something, material, to be the building block of these, let's call them lines of force dispersion. So these lines, these relationships of connective tissue help to maintain shape even when the mass is accelerated to tremendous extent, or shearing forces are introduced by changes in direction. And that's something. That tissue is the connective tissue. So we have adaptive responses in the body to forces, and this is what we have to learn to identify in our exam. Architectural changes within the bone, we don't see them, but they happen. The bone takes years to become fully ossified, calcified. The bone of the child is cartilaginous, and it grows from a certain area, the growth plate. And most bones, particularly the lower extremity bones, have an architecture inside where little units are assembled similar to that aqueduct I just shown. So the femoral head, the femoral neck, and the femoral shaft, they are an arch, and they have actually inside, if you see the trabecular system, you see that the trabecular system will form an arch within that will send the forces in the most optimal direction. It's rare, but it occurs if you abuse the ability of the bone to withstand compressive forces, you can have, because you're now about to turn 40 or 50 and then you want to run a marathon. And we've seen that many times. By the way, it's an example from practice. And then all of a sudden, this hip pain, and then the x-rays, a stress fracture. So even the good architecture can fail. But if you do it progressively, the bone will sort of maximize its density. Same with the muscle. If you train the muscle will improve the thickness, the cross-sectional area, the density of the connective tissue, and there'll be as well improvement in the energy generation of the muscle cell that will help with the behavior of the micro uh, mechanics of the muscle, of the actin, myosin, tropomyosin. All right, so I will leave this here and then just invite you to explore that, which is a fascinating topic to me. The game, I call it the Game of Forces, and I find it more interesting than the Game of Thrones that many of you probably watch. I didn't, so I'm just biased there. I will not withstand 8 seasons of anything. There's nothing so interesting unless it's a nature program. In that case, I would watch it. So, in clinical practice, one of the things that are going to give us is strategies to not just interact with the nervous system. And so far, we've thought nervous system, everything is being nervous system, so topographic, functional, via movement. Now we can examine the body and sort of read what adaptations may have taken place. Of course, we observe the patient and we can see, based on the posture, identify areas of weakness, like here, an excess kyphosis, a rectification of the lumbar lordosis, typically means tight hip flexors, weak scapular stabilizers, an extensor, weak neck extensors, tight hamstrings, weak tibialis posterior. So you can already, by observing interaction with gravity, uh, identify targets that are part of the dynamic uh, subdivision of the system. So there is a part that is not that dynamic, let's say the bone, but the muscles are very dynamic. It's not the same if the muscles engage or if they don't engage. You can even change your posture right away. If you tell someone, okay, stand straight and then chin in a little bit, so you can activate those muscles, activate the scapular stabilizers, etc. And we have exercises that will as well promote better function. And here in this diagram, you can see from the first to the second different uh, shifting of the ideal line of gravity, the line through which ideally gravity should pass. And that line ideally will go from the tragus on the ear to the glenohumeral joint to the center of the femoroacetabular joint to the lateral malleolus. So when the body segments are aligned in such a way, the optimization of the compressive strategies to handle the ground reaction force are optimized. Therefore, less energy is consumed. These other postures are perfectly possible. Many people have them, as it is also perfectly possible to buy on credit. But if you don't pay the credit card in full and you pay 29% daily interest, like many cards charge, is going to be a losing proposition. because there'll be no energy left for anything, no money left for anything. So part of the equation is that improved force management equals less energy spent, therefore more optimal performance of movement. Then that's why the best athletes move better, because they don't waste energy in patterns that are not ideal, because they have moved the proper way, and they train and they maintain elasticity of their tissues, and that allows for optimal body mechanics. So in our optimizing the needles, the location of the needles, the secret number 7, the target selection. At the end, we keep talking all this in the quest to find the best insertion. And the best insertion is not just the insertion that interacts with the nervous system at the most relevant level, which of course is foundational to our system, but also there are parts of the treatment that are aimed towards some of these adaptations that are triggered by the force management task, that the invisible task, but the universal task that the body cannot stop doing. Whether you like it or not, you have to absorb and disperse reaction forces generated by your body mass and the way you choose to move. There's no escape to that. So for optimal selection of treatment targets, like I have here, different examples of treatments for different goals. Here on the left, this would be a recovery treatment that has very minimal material dimension, is purely neurological. What we want with this system that has been at maximum activities is after running one of the heats on the 100 meters. This female athlete, Shana Pintusevich. So I would do a little multisegmental on the reflex visual area for the suprarenal glands, which are the foundation of adaptation to stress. And I would do some posterior chain along tibial nerve. So I would go here, tibial nerve, and again, tibial nerve at the medial malleolus area. Low frequency, 1 hertz, some needles you don't see on the head and the ears. And all this would be to help modulate sympathetic activity, calm down the system, and prepare the system. This plus flushing, lymphatic drainage, etc. Good meal, good night of sleep. That would prepare the body for the next day. The middle is a different treatment, and in this case, there's a combination of things. There is some ongoing discomfort on the medial hamstring of the right leg. This is a high jumper, Amy Acuff, and which, by the way, Amy became an acupuncturist after she retired because of her exciting experience with the needles. And in this case, we would combine neuromotor activation here of the posterior chain extensors, the gluteus maximus, the gluteus medius, plus a reflex axial input on the either the reflex vascular sympathetic area, which seems a little low, or in this case, I think it's more to support the modulation of the vascular system and the somatic nerves on the affected area. So this is a discomfort, but it's not preventing her from competing. But after the treatment, she'll feel way better, because this will change things locally, improve perfusion, and through also manual treatment, we would help reorganizing connective tissue. So we will improve force management. So the acupuncture treatments, neurofunctional acupuncture treatments get now expanded to this supporting the force management. And there are so many elegant and effective ways of doing this that we will talk about. For instance, in your low back pain patients, you don't touch the back. You can't do anything on the back. It's a back that is had already broken facet joints, bulging disc, surgeries, you name it. All right, I am touching the back, but I can improve the force management system that starts at the first metatarsophalangeal joint on the foot. I can improve the talocrural joint. I can improve the subtalar joint. I can improve the eccentric contraction of all the lower extremity muscles that participate in the absorption of forces during the pronation part of the gait or the running, with the tibialis posterior, the long head of the biceps, and without touching the back, I'm helping the traffic. So the example that you will all understand is this of the traffic. If I want to fix a traffic jam on downtown Toronto on the Gardiner, I will not go there. I will not try to remove the cars from there because they have nowhere to go. What I will do is go several kilometers away and start distributing the traffic elsewhere. So no matter how slow it moves, after a while, if you stop feeding new traffic, the traffic jam disappears. So that's what you do when you have a body part that you want to protect. You will help the force management system, and for that you need some sort of assessment that integrates all these ideas that we've been talking about in a very simple manner. So the idea is to identify which adaptations may have taken place due to overload of certain tissues, and which articular factors are as well part of this, which will be restrictions. So restrictions or movement capability, those are critical parts of your assessment that will give you the ability to restore force management, which is indispensable uh, in the athletic community. If you see this guy's doing a wall squat and you see how he's going to fall because will not be able to generate, oh, he didn't. All right, so this is after the treatment. Before the treatment was falling behind, didn't have enough hip flexion. Now clearly has improved quite a bit. The hip flexion, cheating a little bit. You should do it without touching, but anyway, it's way better than it was before. And this is what visually you should come up after a good assessment that I call neurofunctional mapping, where you would have, let's say here, right ankle is an area that suffered trauma in the past and that still has some residual restriction due to that. This is very common. Then you have an area that has quite change in tensional behavior, is very tight. Okay, then you have an area that could be weak, inhibited, etc. So this neurofunctional mapping is the process of organizing clinical information in pain with movement disorders according to all the levels of neurological relevance, plus the understanding of the movement mechanisms involved in force management. And this truly becomes your limiting factor on one hand, but also your power. If you're good at movement analysis integrated with the identification of adaptations, then you already have the ability to create hypotheses. So here I can create a hypothesis saying, all right, the original injury here created an impairment on the force management system on the whole extremity. Pronosupination was impinged. Likely muscles and joints involved in pronosupination were affected, and you can test that and identify, okay, tibialis posterior is very weak, it's inhibited, peronei are very weak. So here you have already two targets. You can go to tibialis posterior, very easy, spleen 6, done in a more material manner with the intention of generating a contraction, and we'll do that when we finally do cases. And the same with the fibularis muscles. You can do the fibularis brevis directly over the muscle. You can do the longus, go to the superficial branch of the fibularis, the fibular nerve, and that will trigger eversion via contraction. So already with the first part of the hypothesis, you can change the whole behavior of the kinetic chain. But you can keep going and identify, say, oh, due to this prolonged restriction, pronosupination, also the tibiofemoral rotation has been affected, and there is a tightness, a restriction here on the hamstrings, more the median hamstring, more the lateral hamstring, both. So you can go and needle this and relax the muscle, and that will improve the mobility and the knee. And that, together with the stimulation of these prime movers of the ankle region, you will have a restoration of neurobiomechanics, but not just neurobiomechanics for optimal movement, but for optimal force management, which entails decrease energy expenditure. So all of a sudden, the athlete moves better, moves faster, and doesn't get as tired. And on top of that, you take away extra work from the tissues, let's say the hip flexor. Now, this person came to you with a complaint of discomfort here on the inguinal region, and if all you do is go into where it hurts, then you will miss completely how to really fix this problem, because this is a force management problem. So in the assessment from the history to the observation and the qualitative movement analysis, you need to have present this invisible task of force management, because that is what's failing. So all back pain problems are failures of the suspension system, because the back, if it gets the help of the tensional system of the lower extremity with proper pronosupination, proper eccentric contraction of these many muscles, deep posterior, long head of the biceps, short head of the biceps, semitendinosus, membranosus, etc. By the time the forces, the reaction forces reach the back, they'll be of a small magnitude, and the tissues of the back will be able to handle it. So people have back pain not because they have excess forces in the concept of reaction force, but because those forces are not handled lower down, so they reach the back. So the back is the victim, is not the problem. The inguinal region is the victim, is not the problem. Indeed, it's very rare that the problem is primarily the proximal area, because the proximal area is the one that has the greatest adaptability, the greatest adaptive potential because of mere size. So if this area fails, you have to assume correctly that down the kinetic chain, the forces are not handled properly. The traffic is now sent to one. So now they close all the lanes and there's only one lane open. guess what is going to happen? That wherever that lane goes is going to be a huge traffic jam and damage of the asphalt, and after a while that road is going to be destroyed. Now you cannot blame it on the road because the road is designed for certain traffic. If the other lanes were open, there'll be no problem with this road. So you want to improve the back, improve force management of the extremity. In athletes, this, what I'm telling you, is the only way. The only way to really prevent recurrent injuries. Why recurrent injuries are so frequent? The body can heal. Some people break a bone, they never break it again. Some people tear a muscle, they never tear it again. So why some athletes are having the same injury again and again? Because nobody is correcting the true dysfunction that's leading to the overload. So this absurd concept of repetitive strain, and I say absurd because the traffic, the road is designed to absorb the traffic. If the traffic goes well spread among all the lanes, there should be no overwearing of one. Obviously, in the roads, all the time the right lane is worse because of the tracks, which are the biggest ones, and there you can see the mechanical factors at work. The right lane, even in some highways, is completely destroyed with the left still in perfect shape. So that tells you the importance of dividing the force management task, and that's what the tensegrity and the microtensegrity do. So if you embrace this and understand this and start practicing it with your hands, with your eyes, you will be in a new position to design a lot more elegant and effective treatments because you will not only neuromodulate the contributing factors to the pain problem, which is the next group of discussion, but you will restore adaptability in the system, which is a superior uh, form of treatment. It's like you send people to the gym, they get in better shape, they feel better. Uh, a neurofunctional treatment that takes these kinetic chain factors into consideration and force management is equivalent to going to the gym. So I'm going to leave it here and I will take your questions and the next day we'll wrap up. I think I'll be able to wrap up to get ready after that to start few cases to exemplify how superior understanding of the whole set of elements involved in a given pain with movement dysfunction, which are not just structural, which are not just neurological, but they are also biomechanical, neurobiomechanical, neurometabolic. That the cleaner the understanding, the more effective strategies will come to us. We already have the tool, the needle and the electrical stimulators. It's just how to use them in an optimal manner. That is what my quest here with these presentations is to lead you to that promised land.
Thanks so much, Dr. Elorriaga. I just want to let everyone know that I will be posting some articles that Dr. Elorriaga has forwarded us, and they will be attached to the recording link when you get that in a couple of days. Are there any questions that anybody has from tonight's presentation? If not, I just want to remind people, I know that this is part 5, so there's a lot of information that Dr. Elorriaga has shared with us. And please feel free to email us. We can always catch these questions on the next part. We've had people do that before, so we can, we'll make sure that everyone gets paid attention to. We did have a question with a chronic dysfunction with multiple compensatory changes. Where would you start?
In a chronic dysfunction with multiple
Compensatory changes.
compensatory changes. That is a very good question, and this goes back to a proper evaluation of two things: what happened, how it happened, and what resources are still available. So the how it happened, it could sometimes lead to a picture where obviously not always is possible to reverse everything. Let's say you have a fracture, you change the direction of the bone, now you have to adapt to a new position, a new dynamics. So the way I approach it is exactly like this. I first try to understand what happened. And if there is a or primary event, I have like a rule, and is I go to the oldest first because I want to see ground zero. Ground zero was a fracture. Ground zero was a surgery. Ground zero was a sprain. Then I go there and I see how is that? Because maybe still there is a lot of adaptability left there that the body simply is being protecting. So go to the oldest part of this set of adaptations. If it's mechanical or metabolic, or try to figure out, because it could be both, it could be metabolic as well as mechanical. This person started to do too much of certain thing and to fatigue certain elements of the kinetic chain. So do an evaluation of the kinetic chain with a historical perspective. And once you have that picture, then do inventory of available adaptive mechanisms. And same, adaptive mechanisms could be metabolic. So that would involve aerobic exercise, nutrition, supplementation. Neurological, that would be our forte. You can always restore neuromotor function on the prime movers, on the stabilizers. You can do your manual testing and then stimulate those muscles that are not performing ideally. And finally, improve the force management system by making possible open more roads. How do you open more roads? Movement capabilities and better tensional behavior. Movement capabilities, you go to the articular regions and improve uh, accessory movements, improve pericapsular tissue dynamics. And that can be done partially with needles, partially with the hands. And finally, improve the eccentric contraction ability of the muscles, introduce some eccentric contraction training, such as very slow squats, for instance, or doing very slow descending from the bar on the upper extremity. All eccentric training will reinforce the tissue, muscle, connective tissue, tendon, and facilitate force management. And finally, with your hands, you can go and clean up some areas that have accumulated edemas, microedemas. So this would be the approach. Your two-prong analysis: what happened, try to understand maximally and address what's still available, and then inventory of adaptive mechanisms, including metabolic, neurological, neuromotor, movement capabilities, and tensional behavior.
It's a lot to work with in there.
Well, what is to say, absorb all the theory about chess, become a grandmaster, and then you can sit down and play good chess.
As sensory nerves carry the pain signals from distal part towards spine, is it better to target acupuncture to sensory nerves to get target nociception?
Okay, I don't think I fully grasped the question. Can you repeat it?
Let me see if I'm reading this properly. So, as sensory nerves carry the pain signals from distal parts towards the spine.
So sensory nerves, nociceptive fibers, are
Mhm.
the only fibers that can carry bad news. There's no pain. There's no pain information. Pain is a central event. It's a brain event. We established that. So the correct phrasing of that is that sensory nociceptors. The nociceptors are the primary contributors in the periphery to the amount of information that will then lead to a pain experience. Thus, the three articles that you're going to receive speak precisely about the 10, 11, actually, 11 factors, 10 in the articles, but I'll give you the 11th, which is neuropathic behavior. So the pain game can only be analyzed from top down. That's it. So, but what was the technical part of the question was?
Is it better to target acupuncture to sensory nerves to target nociception?
Uh, that if you remember, I mentioned that neuromodulation mechanisms are several, and there is a hierarchy of information handling by the central nervous system. And the central nervous system prefers information that is not nociceptive. So the best way of handling that is not to go to the nociceptive fibers, but to go to the non-nociceptive fibers, that which is the natural reaction. So if you hit your elbow and it hurts, the first thing you do is you put your hand there, and that alleviates the discomfort. That's a prime example of neuromodulation. Your acupuncture needle should do exactly this. So this is not trying to fight the nociceptive signals. Nociceptive signals continue at the same rate that they were before, but by generating stimulation of mechanoreceptors that transfer light touch and and, uh, and light pressure, when these signals reach the spinal cord, they block the nociceptive signals from the area. So the best way of neuromodulating nociception is to increase the traffic of sensory signals from the same segment that are not nociceptive. And this is the natural way. Remember this, same. So in general, that is the universal number one neuromodulatory strategy that we have with hands, needles, etc. Obviously, if you can use eyes or other means to decrease nociceptive signaling, decrease inflammation as well. But in general, it's not good to go against these angry fibers.
It's interesting to have you explain the information again. I think that you were talking about the pain parts, even in part one already. So, thank you for bringing it back around again. It's good to have
Well,
a
it's
few
complex. You
reminders.
have to keep going back. It's not easy to build such a complex system. We're trying to learn this town. This is like the old exam for the cab drivers in London, that it took several years for them to memorize. They had to commit to memory all the streets of London, which are very many, and before the GPS. And these cab drivers also they've been examined, and the part of the brain that deals with the spatial information that it would grow. So we are a little bit like those old-fashioned cab drivers that had to commit to memory enormous amounts of information and then practice in order to really be able to handle that with fluidity. Don't expect that to happen right away, and don't expect that quick and dirty. I told you from day one, this is your introduction to complexity, which is reality. But this is also your access to tools that will multiply the clinical success of your practice.
Thank you very much. Are there any other questions from people? I know there's always a lot of information. If not, we will say goodnight to everyone and thank you again for joining us. And we will be back with part 6.
Thank you very much. Have a good night, everyone.